Imagine a patient who stands with perfect physical stability, even as their internal perception spins completely out of control. The patient is a 50-year-old male who suffered a left cerebellar infarction. He arrived at the clinic with severe rotational vertigo and postural instability so extreme he required constant assistance to prevent falls. Following 28 days of vestibular rehabilitation, his physical recovery was remarkable. His mini best test score, a measure of functional balance, rose from a near total loss at 3 out of 28 to an independent 26 out of 28. Yet, despite this independence, his internal symptoms remained severe. He still reported a 5 on the numeric rating scale for vertigo, and clinical tests showed unyielding left beat nystagmus. In peripheral vestibular injuries, like those in the inner ear, symptom resolution and balance recovery usually correlate. In this central cerebellar case, the two metrics moved in opposite directions. This case study demonstrates that the neural architecture governing functional balance control is distinct from the pathways governing vestibular perception. The patient did not resolve the underlying vestibular deficit. Instead, the brain executed a measurable process of sensory reweighting to maintain posture. To understand the recovery, we must first isolate the specific neural circuitry destroyed by the stroke. Acute phase neuroimaging shows high-intensity infarction signals located in the left cerebellar hemisphere and vermis. Looking closer at the level of the inferior cerebellar peduncle, we can identify the specific structure responsible for the patient's distress, the flocculonodular lobe. In a healthy brain, the flocculonodular lobe sends inhibitory fibers to the ipsilateral vestibular nucleus, acting as a functional brake. When the infarct severs these fibers, it triggers central disinhibition. Without this brake, the left vestibular nucleus enters unchecked hyperexcitability. The brain interprets this asymmetric central hyperactivity as constant, violent rotational vertigo. But this was not a muscular failure. The patient maintained perfect scores of 34 out of 34 on the Fugl-Meyer assessment, ruling out motor paralysis as the cause of his instability. Instead, the crisis was purely neurological in nature. The central nervous system was receiving intense, unbalanced spatial signals it could no longer interpret. At day 7, clinicians precisely measured how the patient's brain was attempting to compensate for these chaotic, disinhibited vestibular signals. They used the Modified Clinical Test of Sensory Interaction and Balance, or MCT-SIB, to quantify which senses were keeping the patient upright. The initial MCT-SIB data revealed a severe skew in sensory reliance. The patient used somatosensory feedback for 21.6% of his balance, vestibular input for only 15.5%, and vision for 62.9%. This reliance on visual input exceeds 2 standard deviations from healthy norms. This visual dependency was so extreme that the patient reported intense vertigo simply from observing the swirling water in a toilet. To understand the biomechanics of this instability, clinicians used fast Fourier transform, or FFT, frequency analysis on the patient's center of pressure. When the patient closed his eyes, the FFT data showed massive Cauer spikes in the low to mid-frequency range, specifically between 0.1 and 0.5 Hz. Spikes in this 0.1 to 0.5 Hz range characterize the breakdown of balance in a patient with an uncompensated unilateral vestibular impairment. At baseline, the central nervous system was in a state of breakdown, desperately clinging to visual data to override the corrupted vestibular network. Because the infarcted cerebellar tissue can never recover, rehabilitation therapy had to force the surrounding central nervous system to adapt. The primary intervention was 40 to 50 minutes of daily vestibulo-ocular reflex, or VOR, cancellation exercises. In the passive phase, the physical therapist rotates the patient's head and trunk while the patient maintains a fixed gaze on their thumb. The protocol then progresses to the active phase, where the patient leads the rotation, increasing the cognitive demand of the task. Through continuous daily repetitions, this habituation process successfully works to reduce the excitability of postsynaptic potentials in the hyperactive vestibular nuclei. While this intense therapy did not correct the fundamental vestibular asymmetry or the patient's nystagmus, it triggered a powerful secondary survival mechanism. This is central substitution. the process where the brain hunts for alternative data streams to replace the corrupted vestibular input. The daily repetition physically forced the brain to abandon its failing visual dependency and adopt a completely new strategy for spatial awareness. By day 35, the final assessment revealed the structural results of this neural restructuring. Comparing the day 7 sensory reliance against day 35 results, the brain prioritized other inputs. Visual dependency shrank from 62.9% to 36.2%. The somatosensory slice expanded from 21.6% to 57.5%, becoming the primary driver of balance. This is sensory reweighting. The central nervous system shifted its trust from the eyes to the proprioceptive feedback of the joints and feet. The final FFT frequency data confirms this stabilization. The low to mid-frequency spikes have flattened into a stable baseline. The elimination of high-frequency sway proves the CMS successfully adapted from a state of breakdown to a continuous postural control model. By building a somatosensory bypass around the noisy vestibular signal, the brain restored the patient's independent walking ability. This brings us to the core paradox. If the balance system was successfully rewired, why does the patient still feel severe vertigo? The patient's capability and his experience are now entirely separate. Vertigo and nystagmus directly reflect the core vestibular asymmetry caused by the cerebellar lesion. Balance is a composite, adaptable function. It can leverage alternative sensory inputs when the primary system is compromised. While the red vertigo pathway stubbornly persists, a new somatosensory to motor pathway successfully bypasses it to control the muscles. This indicates that subjective vertigo intensity is a poor proxy for evaluating a patient's functional balance capability. In central lesion patients, rehabilitation must focus on forcing somatosensory adaptation. Functional independence can be achieved even if the subjective sensation of dizziness never fades.